Hi, everyone. I'm Dr. Michael Richmond, double board certified cardiothoracic surgeon. So, as most of you know, skier Lindsey Vonn suffered a severe lower extremity injury from skiing during the Olympics. So, not only did she suffer a complex tibial plateau fracture, she also had a lower extremity compartment syndrome, which you heard about yesterday when she came forward and discussed it. So, those of us who've done a tremendous amount of trauma surgery have an extensive experience dealing with this potentially catastrophic problem. So, what is it? Well, in a nutshell, it occurs when the pressure within a defined compartmental space, in other words, a space enclosing the muscles, increases past a critical pressure threshold. And this decreases the perfusion pressure, in other words, the blood coming through the artery to that compartment. So, in general, longer periods of compartment syndrome and ischemia, which means lack of oxygen, correlate with worse outcomes. So, ischemia of only 1 hour is associated with reversible neuropraxia. And neuropraxia is disorder of the peripheral nervous system in which there's temporary loss of motor and sensory function due to blockage of nerve conduction. And that can take about 6 to 8 weeks before full recovery. Okay, so if you have lack of oxygen or ischemia for 4 hours, you can have what's called irreversible axonotmesis. And axonotmesis is an injury to the peripheral nerve of one of the extremities and affects both motor and sensory function beyond or distal to the point of injury. And that's lost completely over time. Okay, so they lose complete nerve function. Ischemia 6 hours or more is associated with irreversible death or necrosis of the muscle. And obviously that produces horrible functional impairment. Okay, where does it occur? Well, it can occur in any area of the body with closed compartments. Below the knee is the most common area to develop compartment syndrome. And that's followed by the forearm, the thigh, the arm. So the key is to rapidly diagnose this. So basically, based on the injury, you need to start thinking about it. And prompt, accurate treatment leads to the best outcomes. So what are the causes? Well, trauma is the most likely precipitating factor, and fracture of the extremity leads to the greatest number of cases of compartment syndrome. But I've done so much trauma, and I've seen it with gunshot wounds, stab wounds, motor vehicle accidents, crush injuries, people getting hit by cars, and the list goes on. The key thing is, though, a delay in the diagnosis of acute compartment syndrome can have devastating consequences for the patient. In other words, Lindsey Vonn was saying if she didn't have it done or treated, she could have lost her legs. So early suspicion of the disease should invoke an immediate response. And the classic signs of compartment syndrome are the 6 Ps. And that's pain, paresthesias, poikilothermia, that means difference in temperature, pallor, which is whiteness, paralysis of that part of the body, and pulselessness. Pain is usually the initial complaint and should trigger the complete workup of acute compartment syndrome. All patients at risk should have early and frequent repeated physical exams to assess for pain in the muscle compartments. But a clinical diagnosis of compartment syndrome must be followed by prompt surgical decompression. In other words, if they're complaining of something, you just need to go in and do something. And the diagnosis is often unclear. And if that's the case, you need to do pressure monitoring. In today's practice, we do that with a device called the Stryker system. And basically, we insert a needle perpendicular to the skin into the muscle compartment in question. And traditionally, a intramuscular compartment pressure of greater than 30 millimeters of mercury was used as a diagnostic threshold for diagnosing compartment syndrome. Now, there's different kind of equations, but basically that's the traditional diagnosis. But because of the subjective nature, the absence of pain cannot negate the possibility of compartment syndrome. So you got to go by clinical suspicion. Now, what's the treatment? The traditional treatment for lower extremity compartment syndrome is a 2-incision, what's called 4-compartment fasciotomy. So in the first picture, you're going to see a cross section of the left leg below the knee. Okay. In the second picture, I've highlighted in purple, you're going to see the connective tissue, which is known as the fascia, which basically, if you buy like meat, like a tenderloin, you're going to see that silver skin around it. That's the fascia, and it surrounds all 4 compartments. So that's what we release through the medial incision. And I'm showing you the cross-sectional area. Remember, the leg goes up and down, okay? So the incision is long. So through that incision, we're able to decompress the 2 posterior compartments. So there's a deep and superficial compartment. And through the lateral incision, you can decompress the anterior and lateral. Okay? Unfortunately, complications after fasciotomy are not rare, and 1/3 of the patients receiving fasciotomies will end up with postoperative complications, including death of soft tissue, the wound breaks down. Eventually, when you close it, sometimes you do skin grafts and those get infected and need debridement. And some people, even when you do it, require amputation. Vascular injuries leading to fasciotomy are associated with significantly higher rate of complications than patients without vascular trauma. In other words, do they have an arterial injury at the time of the initial accident? So with that, hope you learned something today. Thank you for listening. For more information, guidance, advocacy, or consultation, you can go to my website at www.paladinmds.com, and have a good day.